Yeah, good morning. So today we start with the high yield questions of psychiatry. As we all know, psychiatry is a small subject usually asked in FMG and every exam, but it is the main subject. I always say that if you revise the psychiatry, the whole psychiatry can be revised in 2-3 hours. And we try to make an attempt to take up all the MCQs which we can learn in this time. So we done this last time also, and out of that 100 questions, there are about 7 questions in the last FMG. This time we curtailed the number of the questions to 50, and we see that if at all we have all the FMG questions this time from this 50 only. So 50 bus, and this 2 hours I think should be sufficing our need to the revise. It's basically a revision of psychiatry as per best of my understanding. So welcome you all and thank you all for joining. And now we start with the psychiatry. The first question basically is the someone saying that my daughter wants to kill me. If it is not a reality, it is a delusion. We all know delusion is a fixed belief, firm belief, false belief. Fixed, firm, false belief held with undue conviction, not shared by others, and not matching with the socio cultural background. So it's a fixed belief, firm belief, false belief held with, good morning, Dr. Sahab, the held with undue conviction, not shared by others, and not met with the socio cultural background. Okay, well done. So we'll learn magical thinking is that merely by thinking, magical thinking is merely by thinking, action would happen. Action would, सोचने मात्र से ही कार्य हो जाएगा. Merely by thinking, the action would happen. That is the magical thinking. Hallucination, illusion, we know they are the disorders of perception. So disorders of perception are the hallucination and the illusion. Illusion we all know. Illusion we all know. So this is not only the revision of the 50 question. Trust me, it is basically the what do you call the revision of all the important topics. So it is not previous year's questions we are doing, it's a previous year's topics we are revising, which has been commonly asked in the examination. Illusion, we know it's a misperception of stimulus. Stimulus is there, but I misperceive it. That is what is being called as the illusion. On the other hand, hallucination is a perception without any stimulus. Nothing is there, but I am seeing something, I am hearing something. That is what is being called as the hallucination. And please mind, it is as clear, as real, as three-dimensional, as live, as vivid, as you are all hearing me and seeing me. If at all, I would not have been live with you. So it has all the qualities of a real perception. And it is in the objective space. It is in the objective space. There is no voluntary control. And the inside is absent. That is the characteristic of a hallucination. And It is a game at the cortical level. Sensory organs are not involved. Sensory organs are not. So that is the disorders of the perception. So we have a simplest lollipopest MCQ that the hallucination is a disorder of the perception and delusion is a disorder of the thought. So it's a disorder of the thought. So for the FMG, this is the lollipopest MCQ of the FMG that the delusion is a disorder of thought and hallucination is a disorder of the perception. Okay. Again, now lady having a 2 depressive episode in the past now has low mood, restlessness and started saying that it's the same question. So it's basically a severe depression with psychotic symptom. So it's basically the recurrent depression with psychotic symptom. Okay. So we know we will learn depression in a bit. Okay. So we know what in English we called as depression. In psychiatry it has been called as the major depressive disorder. And please mind, we have to remember that in psychiatry the mood has to be persistently, pervasively low for 14 days. And psychiatry, we have learned, we have to remember that psychiatry diagnosis is nothing but the cluster of symptom making a syndromal diagnosis. So in this case, the depression symptom, we must appreciate that we have the major symptom like sadness of mood, lack of interest, and lethargy. These are the 3 major symptoms. Then we have the poor attention and concentration, forgetfulness, decreased appetite, weight loss, decreased libido, decreased sleep, and classically we have a early morning awakening. नींद जल्दी खुल जाती है. That's a symptom of the depression. So we all know the depression symptom, but I'm just enumerating them all so that we are able to remember them. Okay. Now 5th is the crying spells. Excessive guilt. बहुत पाप करा मैंने. I'm guilty, feeling too much. Pessimistic view of future. And ideas of hopelessness, helplessness, worthlessness. Nothing could help me. भगवान इससे अच्छा तो मुझे उठा ले. सुनता नहीं वो तो मैं ही आत्महत्या कर लेता हूँ. सुसाइडल आइडिया अटेम्प्ट कर लिया मैंने. सुसाइडल. So that is the, good morning Dr. Varsha, that is the classical symptom of the symptom list of the depression. And we know nothing major about it. We have major depressive disorder mild, we have major depressive disorder moderate, and we have the major depressive disorder severe. My only point of telling you is that nothing major about it. It's only the another name for the depression in psychiatry. We call it as a major. So it is very simple. 2 plus 3 for 14 days is called as the major depressive disorder mild. 2 plus 4, I hope you remember the blue color and this dark color. So any two of that blue and any three of the down black for 14 days regularly is called as the major depressive disorder, mild. And any two of that, any four of that will be called as moderate depressive episode. And anything more than 2 plus 3 will be 2 plus 4 will be called as the anything more than 2 plus 4 will be called as the it is two type severe depression without psychotic symptom, severe depression with psychotic symptom. तो डॉक्टर साहब साइकोटिक सिम्टम क्या क्या हो सकते हैं? कानों में आवाज़ें आ रही हैं, चलो चलो आ जाओ, बहुत हो गया, नीचे आओ आओ, आत्महत्या कर लो. Somebody hearing voices asking him to join above. Or I am having a Cotard syndrome, nihilistic delusion. I am ending, my intestines are rotten up, kidneys are damaged, brain is no there, mind is no there. It's a Cotard syndrome. Or I may have a delusion of guilt. So not just guilt, it's a unduly delusion of the guilt. Okay. Now, why should we differentiate? We see that lady is having a recurrent depressive episode. Now she is suspicious that somebody wants to kill him. So it's a depression with psychotic symptom. With the psychotic symptom, the treatment of choice is electroconvulsive therapy. We'll appreciate that in understanding we feel that anybody we don't know any treatment, we give the electric shock in psychiatry. But that's not the case. In psychiatry, the electric shock has been reserved now for the catatonia, severe depression with psychotic symptom, or uncontrolled aggression. So that's, we must know that electric shock is a treatment of choice for the severe depression. Okay. Let's come to the next question. Now this gentleman is having a recovered. He has fever and he is fear that he may die of curated tachycardia, tachypnea for past 3 months. The most likely diagnosis is it's a post-traumatic stress disorder. We know what is post-traumatic stress disorder. There is a stressful event. And after that event, that is a recurrence happens. So I just write it up. So it is being qualified as the acute stress reaction or PTSD. Just example to appreciate that. Now somebody has purchased a car. Well done, Dr. Sandesh. Well done, Dr. Varsha. Somebody has purchased a car and he planned to go to temple with a car. And while he was just outside the car taking a prasad, there is a bomb blast and whole family blown off in air in front of his own eyes. And he is asking, where is my family? Oh, they all died in front of you. I don't remember that. So that is called dissociative amnesia. But in the post-traumatic disorder, what happened? That this scene is repetitively coming in front of his eyes. Repetitive, the images of that event, reliving experiences, illusions, flashbacks, dreams. Now somebody experiencing these dreams, what will happen? He obviously will be in a shocking state. He'll be in a numbing state. He or she will be hyper alert. And since that time I am not able to go to temple, or I'm not able to buy a car. So in fact, it's a triad of the three things: repetition of the trauma memory, the emotional response, and the avoidance. And we say that less than 1 month it is being called as acute stress reaction, more than 1 month it is being called as the PTSD. So less than 1 month it is being called as the, and it is the PTSD. Well done. And we had a simple understanding that treatment of choice of PTSD is behavior therapy, and drug of choice of this is the. So psychiatry is very simple. Whenever you don't know the answer is simple. Treatment of choice is behavior therapy and drug of choice is SSR. And among the behavior therapy, the latest therapy which is coming as the CBT, cognitive behavior therapy, and the EMDR, eye movement desensitization, and reprocessing. So that's the latest technique. Commonly we use the CBT, but that's a question that treatment for choice of the PTSD is EM. Now this man takes alcohol for 26 years and he takes alcohol about 1 bottle per day for last 2 years. Now he has a tremor, hearing, restlessness, hearing of voices. At times talking irrelevantly. He is experiencing a डॉक्टर साहब बताओ संदेश जी, वर्षा जी, क्या हो रहा है इनको? अल्कोहल इंटॉक्सिकेशन, अल्कोहल हेलुसिनेशन और delirium tremens. Delirium tremens is a loving MCQ of the FMGE and any exam. So let's have a look at it. But before that, first note what is delirium. Delirium is another name for the acute confusional state. It's another name for the acute confusional state. Well done, Dr. Sophia. Well done, Dr. Sandesh. No, intoxication नहीं है डॉक्टर साहब. संदेश जी, intoxication नहीं है ये. In intoxication, the person will be sedated, but there will not be any tremors. There will not be any, hearing of voices, restlessness, and he will not talk irrelevantly. In intoxication, he will just sedate. Okay. Crazy doctor साहब ये नहीं है. We'll learn, see what is delirium. It's another name for the acute confusional state. And in this what happen is orientation is impaired. पहला काम होता है डॉक्टर साहब, orientation is impaired. Person is not oriented to the time, place and person. And there is a hallucination. It being organic condition, it's a usually visual hallucination. And classically, it's a Lilliputian hallucination. Why we have? See, because he has been taking under question discussion session or the current one. It is up to you and your love. Hopefully, we'll do some half today and maybe some half tomorrow, on Friday morning. Okay. But let's see how. But I think we should do it deep. We should finish it off. It is not a question discussion. It is a topic by revision. So once we do it, we should be clear of delirium and delirium tremens question across the place. And you see that we would be, when the question of delirium will come next in the time, in this paper only, it will be like a cakewalk. Let's see that. So there is a transient and frightening delusion. transient and frightening delusion. And there is a reversal of sleep wake cycle. What is my pattern was that is being reversed. So, and there is a picking behavior called as the oscillation, and that's a and there is a sundowning phenomenon. More of confusion, more of hallucination and disorientation as the sun sets. And treatment of choice is treat the cause. So usually delirium is because of some sepsis, some electrode imbalance, some infection. So treatment is treat the cause. But till the time you treat the cause, you can give the injection haloperidol 1.5 milligram IV, or till the time you treat the cause, you give the injection haloperidol 1.5 milligram IV or IV. So that's a delirium. It's another name for the acute confusional state, and we know in delirium there is a diffuse EEG slowing. Diffuse EEG slowing. Now, coming to delirium tremens, so we all know alcohol is a CNS suppressant. It appears that alcohol is a CNS stimulant, but actually it's a CNS suppressant. Daily I take alcohol, my CNS was calmly suppressed. Every evening, CNS was calmly suppressed. Now, one fine day, I plan to leave alcohol, I left alcohol. What will happen? CNS will become hyperactive. CNS will become hyperactive. So, we'll have a delirium plus tremors plus autonomic hyperactivity. So, there will be increased pulse, increased BP, increased respiratory rate, increased sweating, and increased brain activity. So sometimes they say it's a EEG fastening. EEG fastening. ठीक है डॉक्टर साहब? So that is the question they ask you, that in delirium there is a diffuse EEG slowing, but in delirium tremens there is a EEG fastening. And treatment of choice will be what? Treatment of choice will be treat the cause. Cause here is alcohol withdrawal. Cause here is alcohol withdrawal. So treatment will be the offer him quarter half, but we can't do that in hospital. Otherwise, in the evening, a lot of people will come to take care of your impending delirium tremens. So we'll give something like alcohol, and we give the benzodiazepine. We give the benzodiazepine, and we give the longest acting benzodiazepine, that is chlordiazepoxide. Chlordiazepoxide. So there is a question that the drug of choice for delirium tremens is some benzodiazepine, and most likely it's a chlordiazepoxide. And if delirium tremens plus seizure plus epilepsy or alcohol withdrawal seizure, that we have the injection diazepam. If liver function test not available, we go to lorazepam Because we know these are the benzodiazepine not metabolized by. So if we don't have the liver function test, we go for either lorazepam or oxazepam. So these are all the questions from the alcohol withdrawal. And we complete it like that. Just one point. चलो आ ही गया सवाल. The first side effect or first withdrawal, side effect नहीं कहेंगे डॉक्टर साहब, first withdrawal effect to come. बताओ डॉक्टर साहब. First withdrawal will be नहीं पता लग पा रहा. First withdrawal will be the tremors. The most common side effect or most common withdrawal or the first symptom, first sign of alcohol withdrawal is tremors. Very good. Within 6 hours. Very good. So we know delirium tremens comes within 6 to 8 hours. Hallucination come from 6 to 8 hours. Tremor 4 to 6 hours. 6 to 8 hours. Seizures for 24 to 48 hours. (48 to 72 hours). So this is what is the timeline. So anxiety, insomnia are there, but that is how the first symptom, first sign, first withdrawal will be the delirium, the tremors. That's great. Now 50-year-old man with a 3-year history of irritability, low mood, lack of interest, and general dissatisfaction with everything, and no significant disruption in the sleep and appetite. He is likely to be suffering from the. We have learned now that for depression there has to be sadness of mood, crying spells, and all that. 2 plus 3 for 14 days. Minimum of at least 5 symptoms for 14 days. But in this condition, it's basically a 3-year history, chronic history, and it's a dysthymia. We know in this what happen is subsyndromal depressive symptoms for they never become syndrome. They are basically the for no doubts. Major depression nahi hai ye. It is basically the so it is a dysthymia. It's a C. For depression, there has to be 2 plus 3 for 14 days. Dysthymia, as per DSM-5, it has been called as persistent depressive so it's a persistent depressive disorder. Okay. ठीक है डॉक्टर साहब. There is also a concept of double depression commonly asked in FMG exam. Now, dysthymia is something like a depressive personality disorder. Previous time dysthymia was being called as the कि स्वभाव ही उदास है उनका depressive personality disorder. But in today's world it is being called as the the persistent depressive. So, but it is double depression. Like some people are like that. They are always having a dull mood, lethargic, always complaining, always brooding. But now, what they have been, so it's a double depression. So it's basically the major depressive disorder on persistent depressive, or it has been called as the depression on dysthymia. Depression on dysthymia. So that is the double depression. Again, a very popular MCQ of psychiatry. ठीक है. So that's up. Let's move. Now, 3-month-old child with depression, what is therapy should be prescribed? So ideally, we think that we should go only for CBT, but I think we should not mind giving the antidepressant here as well. It's a postpartum depression, so we should not mind giving the antidepressant along with the CBT. We give the cognitive behavior therapy as well as the CB. ठीक है डॉक्टर साहब? Okay. Now, all are the reason for the cognitive impair in the old age, except the thiamine. Thiamine actually, it is responsible for the Korsakoff psychosis. Basically, it's a misnomer. It's a recent memory loss plus confabulation. Confabulation is filling up of memory gap. So it's not a psychosis, it's a misnomer. It's a recent memory loss plus confabulation. So they ask you that what is confabulation? It's also the filling up of a memory gap. You ask me what you have taken at breakfast. I tell you I have taken the idli vada. Idli vada I have taken when I was in Chennai 4 years back, but I just filled up my memory gap from my previous information. So that's the confabulation. But we know that dementia has been, to understand this, we learn here, the dementia has been called as the reversible and irreversible. Reversible dementia is hypothyroidism, vitamin B12 deficiency, folic acid deficiency, niacin deficiency, vascular. ठीक है डॉक्टर साहब? Irreversible are the Alzheimer's disease, Pick's disease, and vascular dementia. It's a post encephalitic ठीक है डॉक्टर साहब. Post encephalitic dementia. So that is the reversible and the irreversible causes of dementia, or what is called memory loss. ठीक है डॉक्टर साहब. Now, alcoholic develop delirium tremens and other symptom. What should we give? बताओ डॉक्टर साहब. थोड़ा फास्ट. इसमें we will give the thiamine to prevent the Korsakoff psychosis and later the Wernicke. To prevent the Wernicke encephalopathy and later on the Wernicke encephalopathy. Okay. So the immediate aggressive confusional variant with disorientation, with ataxia, with 6 nerve palsy is a Wernicke encephalopathy. Later on the मिथिकोबाल क्यों देंगे डॉक्टर साहब वर्षा जी? तो वी डोंट गिव मिथिकोबाल, वी गिव दी thiamine. सब लोग बोर हो गए, फास्ट स्पीड चाहिए. Sudden and transient muscle weakness while being fully conscious, triggered by laughing and crying. It's a latest trendy MCQ, latest question to understand the narcolepsy. It's a hypocretin. ठीक है डॉक्टर साहब. It's a hypocretin. It's basically a narcolepsy. Narcolepsy, we know it's a pentad of the sleep attack. Sleep paralysis and cataplexy. That is sudden break in the tone of the muscles. We have hypnagogic, and hypnopompic hallucination. And we have the abnormal REM intrusion. The REM will come very fast. Okay, that's a narcolepsy. Okay, that's a. Now next we come on to the next question they ask you is that the most common type of the hypnagogic and hypnopompic hallucination is a visual hallucination. Is a visual hallucination. तो एक ही बचा है, वर्षा जी भी चली गई, संदेश जी, नवाजन, क्रेजी डॉक्टर्स सब चले गए हैं. कोई बात नहीं, विल डू दी सम क्वेश्चंस and made the speed better next time to call you up. And the treatment of choice was methylphenidate, and now the answer is modafinil. Now the answer is modafinil. ठीक है डॉक्टर साहब. Now narcolepsy, I am here. Yes, आप. ठीक है, थैंक यू. तो narcolepsy, so ये एक ऐसा सवाल है. Narcolepsy is a question which made us to believe that if we have to learn the previous year paper, we should not do previous year question. In fact, we should do the previous year topic. Because first they ask you what is all the pentad of the narcolepsy. So you remember this pentad. Then they ask you hypnagogic, hypnopompic hallucinations are seen in narcolepsy. And they say then that most common type of hypnagogic and hypnopompic hallucination is a visual hallucination. Treatment of choice was methylphenidate. Now the answer is modafinil. And then they ask you last one, center lies in hypothalamus. That is the beauty of this question. By one MCQ, they progress to next level. In fact, they go to further level that it is of two types. Type 2 is a iatrogenic. Type 1 is a idiopathic one. It has a association with HLA-DR. So it's a HLA related illness. And in this there is a loss of the hypocretin producing it's a loss of the hypocretin or orexin producing neuron in the hypothalamus. And what happened into this? The cataplexy has to all pentad here, no cataplexy. All pentad of narcolepsy is present along with the cataplexy. ठीक है डॉक्टर साहब. So that's all about the narcolepsy. Type 1, type 2. Type 2 is usually iatrogenic, means it is post-meningitis, post-trauma. That is a type 2 variety of narcolepsy. Now that's a question loving MCQ of the FMG. Person with the depression prescribed a serotonin and noradrenaline inhibitor. Which drug is that? That is the venlafaxine. That is the venlafaxine. We know this is the SSRI. This is NASA. This is NDRI. And this is SNR. YouTube is very late, I think. Going response. Okay. Antidepressant tetracyclic antidepressant, TCA, SSRI, SNRI, NARI, देखिए TCA is a tricyclic antidepressant. This is again very loving MCQ of the FMG. They are interested in knowing the class of a antidepressant. Okay. So we have TCA, we have the selective serotonin okay. This is the serotonin noradrenaline reuptake. NARI is noradrenaline pure alone reuptake. NASA is noradrenergic selective serotonin augmentation. Vidya, yes. NDRI is the noradrenaline dopamine selective serotonin reuptake. So what actually they would like you to know in FMG or in UPSC, especially the medical exam, the medical officer exam. So tetracyclic is the amoxapine. TCA is the imipramine. Clomipramine. Here we have the fluoxetine. SNRI is the venlafaxine. NARI is reboxetine. NASA is mirtazapine. Mirtazapine. NDR is a bupropion. Okay. It's a dianeptine. So that is a classification you must remember in FMG exam. Usually they ask about the SSRI and the mirtazapine, that is the NASA. But this time they ask you about the SNRI, that is venlafaxine. Okay, that's all. Typical characteristic of Alzheimer's disease. Act on which receptor? So which receptor the attention is from, memory is from, Dr. Saab? बताइए. Okay, no, it is a choline. So remember we give the anticholinergic drug. Sorry, we give the anticholinesterase. Drugs used for Alzheimer's disease is cholinesterase inhibitor. Cholinesterase inhibitor. And we usually give the drug donepezil. We give the donepezil. Okay, that's all. So in the Alzheimer's disease, the chemical lag is the choline. The dopamine is excess in psychosis. responsible for so we increase the choline somehow in the patients of Alzheimer's disease. So the chemical responsible will be the choline. Now, excessive concern with the physical appearance, inappropriately seductive, shallow and labile effect, being self-centered and acting dramatically is a feature of which personality? It's a histrionic personality. We take advantage of this question to learn about डॉक्टर साहब बहुत लैग आ रहा है लगता है हमारे उसमें So we take our topic 2 which has been called as the personality disorder. You know what is personality? Personality is a persistent so it is the lifestyle of individual by way persistent pervasive lifestyle of individual. Okay. Secondly, it usually forms in personality usually forms in adolescence. And we say that no personality is good or bad, but if causes dysfunction, it will be called as some personality. तो कोई पर्सनालिटी अच्छी बुरी नहीं होती है, but it's a very good doubt. I think there is a lag is happening. We are at the personality disorder topic. And now we know that in psychiatry, the personality has been learned in clusters. You have cluster A, cluster B, and cluster. Odd and eccentric is a cluster A. B is the attention seeking. Anxious. Okay. A, B, and without answer. In order and recent variety, we have the paranoid PD, we have paranoid PD, we have schizoid PD, and we have the schizotypal personality disorder. ठीक है डॉक्टर साहब. Attention seeking, we have the narcissistic PD, I am the best. Antisocial PD, though we have asked you a difficult question, in the FMG, they usually ask you simple question that the paranoid PD is cluster A, B, C. So it's a cluster A. In anxious, we have the anxious avoidant PD. We have dependent PD. Okay. So we have been simple question that the anxious avoidant personality is cluster C. The dependent PD is cluster C. Borderline PD is cluster B. So they are the simple free marks MCQ. Okay. ठीक है डॉक्टर साहब. Now hypochondriasis in DSM-5 is called as the I think it is not reaching you on time. We are to the next question and I could only see the personality disorder typing I'm doing. No problem, but that's a so we know that the DSM-5, the hypochondriasis is being called as the illness, anxiety. So we have the somatic symptom. Here we had the somatization disorder. Somatoform pain disorder. And we have the hypochondriasis. We have the body dysmorphic disorder. We have the conversion disorder. So it is being called as the somatic and the hypochondriasis has been called as the illness shifted to the OCD. So that is the DSM-5. अब आया है करिए. In hypochondriasis in DSM-5 is called as is a illness, anxiety. ठीक है डॉक्टर साहब. Now identify the treatment for the antidepressant used for treatment for the tobacco dependence syndrome. Dr. Saab. So we have this molecule. We have learned this table. So we know the noradrenaline and dopamine reuptake is the bupropion. Bupro. We learned about the personality. So we had this question and the answer is the bupropion. Okay. Now, which are the hormone used for treatment of the insomnia? It's a common sense question mostly. It's a melatonin. Melatonin, we know it's a hormone released at the time of the sleep. So the same is being used for the induction of the sleep in patients of insomnia. Now, which anesthetic agent is used now for the treatment of severe depression? Now we know ketamine has been used for the treatment of severe depression. Ketamine has been used for okay. Now, if we see this question, this will be very easy appearing to us. Reversible dementia is caused by deficiency of. It is caused by the deficiency of. वर्षा जी जवाब दे रही हैं पर डॉक्टर साहब सॉरी है ये थोड़ा ऊपर नीचे हो गया है. Reversible dementia is caused by deficiency of the niacin. So we know vitamin B12, very good, ketamine. So ketamine news has been very popular suddenly, but recently after death of that Hollywood actor, famous celebrity, it has been taken back. Very good, doctor. So niacin, we just learned the topic that vitamin B12, niacin and folic acid are used for the very good. Now 5 ways of negative symptoms are proposed by. So we know that 4 A's are given by 4 A's are been given by the 4 A's of schizophrenia have been given by the Bloiler, but the 5 A's of negative symptom has been given by the Nancy Anderson. Matter give the first rank symptom of schizophrenia. Kaplan give the term. He coined the term schizophrenia. Given the 4 A's of schizophrenia. Given the 4 A's of schizo. डॉक्टर साहब यही तो गलती है शिरसा जी, यही तो नॉटीनेस है सवाल में कि 4 A's ऑफ स्किज़ोफ्रेनिया दिया ब्लॉयलर ने, लेकिन नैन्सी एंडरसन ने 5 A's ऑफ नेगेटिव सिम्टम. यही तो ट्रिक है डॉक्टर साहब. देखो सवाल करते हैं. सो वी नो दैट साइकोसिस फॉर द फर्स्ट टाइम इन द वर्ल्ड classified by M.L. Kraepelin. Who classified so he has given the term dementia precox. It's a dementia which has come early. So it's a lovely MCQ that the term dementia precox has been given by M.L. Kraepelin. Okay. But the Eugen Bleuler coined the term schizophrenia. Given 4 A's of schizophrenia, namely autism, ambivalence, affective blunting, and associational loosening. Associational loosening, we know it's a loosening of association. There is no connection between the two sentences of schizophrenia. My emotions are being blunted, that is called affective blunting. Ambivalence is not able to decide the for and the against. Autism is what we learn autism today. Okay. But now, what is the but ये किसी को समझ नहीं आएगा. This is 1904. This is 1911. But nobody could find out. So, in 1960, Nancy Andreasen divided the symptom of schizophrenia into positive symptom and negative symptom of schizophrenia. And lately, he given the cognitive symptoms of schizophrenia. Positive means something extra in me. Nobody else is hearing voices. I am hearing voices. It's a hallucination, which is a positive symptom. Nobody believes there is a camera here. In fact, there is a camera here. Nobody believes there is a camera here. I believe there is a camera here. Somebody wants to harm me. Somebody wants to trouble me. That's a delusion. And too much of violence is a positive symptom. Delusion, hallucination, and violence is a positive symptom. Negative means which all of us do, but they can't do. They means schizophrenic patient can't do. So we all have some motivation to live. They have a motivation and anhedonia. They do not enjoy the pleasure. Hedon is a pleasure. Lack of. So, a motivation, anhedonia. Hedon is a pleasure. So, I can't experience the pleasure. We all socialize. They do not believe in socialization. They have a sociality. We all speak language. They either do not speak at all or they just speak 5 words per day. So, that's a absence of language. That's a logia. We all have the attention to focus. They have attentional deficits. We have all the emotions to display. They have the affective. So that is the 5 ways of the negative symptom. Tricky MCQ. 4 A's of schizophrenia were. That is of schizophrenia. The question is 5 ways of negative symptom of schizophrenia. Just to trouble you, I included this question because that will stimulate. That's a 4 A's of schizophrenia, and this is 5 ways of negative symptoms of schizophrenia. Cognitive is lack of the executive functioning or memory. ठीक है डॉक्टर साहब. Now delirium में भी क्या डिक्रीज होगा डॉक्टर साहब? Falling is the neurotransmitter decrease in the patient with delirium. Again in delirium, that is the acetylcholine. Now this question I given it just to know what is onchoporosis. It's a passing of stool at inappropriate places. व्हाट्सएप क्या था ये सवाल? Because in nocturnal anorexia is passing of urine at night urinate bed, by child age more than. So it's a simple question that the toilet training, child learned toilet training by the age of 3 years. The toilet means the stool where to pass, and for the urine passing at night time, the age is the 5. Now, if we just have been very, very clear, very good, Dr. Varsha. So, if we been very, very clear, cluster C personality includes all except. अब ये लॉलीपॉप सवाल है डॉक्टर साहब. Dependent, avoidant, and ancastic, or what has been called as obsessive compulsive. It is the हमारे यहीं स्लो है. बताइए डॉक्टर साहब, का रिस्पॉन्स दिख नहीं रहा है. इट्स अ नार्सिस्टिक. वी नो इट्स अ क्लस्टर. Now, factors predicting the poor outcome in schizophrenia are all except. ना डॉक्टर साहब, ऑब्सेसिव कंपल्सिव पर्सनैलिटी डिसऑर्डर होता है क्लस्टर सी में. What is been called as an ancastic? Yes, it is not maybe that sir. Narcissistic is cluster B. A factor predicting the poor outcome in schizophrenia are all poor outcome. So for you must know good outcome. So anything good outcome is a presence of the mood symptom. Okay. See, please mind, there is a Professor T.J. Crow in 1980. He classified the schizophrenia into type 1 and type 2 schizophrenia. This table is doubly important because if you remember this table, there is a double benefit. That first is that benefit that sometime they ask you in the medical officer exam, the type 1, type 2 schizophrenia kya hota hai. But if you remember this, you will have another free question we'll learn shortly. Type 1 is a acute onset schizophrenia, usually after a precipitating event. Predominantly we have positive symptom, no family history, emotions are preserved, and no CT scan MRI finding, and it's a good prognosis schizophrenia. Type 2 on the other hand is a insidious onset, gradual onset schizophrenia. As such, there is no precipitating event. Predominantly, we have a negative symptom. I hope now we remember what is the negative. Family history is also positive. And when I tell you that negative symptoms are predominant, you know that emotions are gone. There are some accidental or incidental CT scan MRI finding. And it's a poor prognosis. So if you remember this table, the same table applies to the good and the bad prognosis. Same table will be applied for the good and the bad prognosis. Okay. Acute onset, present of the emotional symptoms, somebody crying, somebody depressed. In schizophrenia, emotion present, it's a good prognosis. Just to complete the table, now somebody married, female gender, late age of onset, that is onset after 45 years of age, and family history of bipolarity is a good prognosis. So acute onset with family history of bipolarity, onset after a precipitating event, predominantly positive symptom, emotion preserved, no CT scan MRI finding present, and somebody married, it's a good prognosis of schizophrenia. On the other hand, somebody having a schizoid personality beforehand, and presence of the soft neurological so it's a good prognosis. It's a poor prognosis. Just add two things, that somebody having a schizoid personality beforehand and later develop the schizophrenia will be a poor prognosis. And presence of the soft neurological signs indicate the poor prognosis. ठीक है sir? So that's all about the good and the bad prognosis in schizophrenia. Now, after death of wife, husband is crying, distress, not able to sleep, not going for work, not taking food, lost about 10 kgs of weight, and saying to the God, please take me away. I should be dead in place of her. We both would have died together. That's a normal grief reaction. Okay. But we just take the advantage of this question to learn all the understanding of grief. We all know grief or bereavement is a normal emotional reaction to loss of loved one through process of death. And we know grief starts immediately, lasts for 1 month, at maximum for 3 months. Okay. And it has 3 stages: shock and denial. No, ऐसा नहीं हो सकता. Distress, detachment. Okay. No, this can't happen. This person can't die. That's a yesterday only we met. That's a shock and denial. Distress is that I've been crying, I've been troubled up, not going to the work, not taking food, and I'm distressed. भगवान मुझे उठा ले, उससे पहले मैं मर जाता, हम दोनों इकट्ठे मर जाते. That's a normal distress of the grief. Detachment is that ultimately we have to detach from that. But that's all normal. What's so abnormal about it? So that's a normal grief reaction. Now, there could be two. Now, there is something in psychiatry called as the pathological grief. Either the grief is delayed or it has been prolonged. Or there is some term called as the hypertrophied delayed grief is no grief for more than 2 weeks. डेथ हो गया किसी क्लोज की, 2 हफ्ता हो गया, रोना ही नहीं आ रहा, दैट्स अ डिलेड ग्रीफ. Okay. Grief lasting beyond 6 months is being called as the prolonged grief. And grief more than 2 years will be called as the hypertrophied grief reaction. ठीक है डॉक्टर साहब? Grief more than 2. Okay. So that's the pathological grief. But there is something in psychiatry called as the complication grief. Complication in the grief can be depression, can be psycho. We must know that symptoms of depression till death wish in background of death of loved one, background death of loved one. That's how there is a lag. So is normal grief reaction. नींद ना आना, दिन रात रोते रहना, हर समय उनकी याद आना, काम पे ना जाना, till that time it's a normal grief reaction. Till death wish. It is till death wish. For causing depression, calling it to be depression, it is the somebody making a active suicidal attempt. Active आ रहा हूँ मैं भी आ रहा हूँ, ऊपर रहेंगे इकट्ठा हम दोनों. That indicate the depression. Somebody making a active attempt of suicide or somebody making a excessively guilty. थोड़ा बहुत guilt होता है. Somebody excessively guilty about death of a loved one. It is because of all my fault that that gentleman dies. And the anniversary reaction that indicate the depression. And last is the mummification. Mummies, we all know, embalming the body and keeping the body after death. It's a mummies. But that is not possible nowadays. So what is mummification? It is freezing the belonging of a loved one. Family believe it's a love. Psychiatry say it's a sign of a depression in the family. Now, any delusion, any hallucination is a ऐसा लगा वो है, खुशबू सी आई उसकी, होता है, आभास हुआ उसका, जुल्फ लहराई उसकी, टिल हेयर इट्स अ नॉर्मल ग्रीफ रिएक्शन. लेकिन सच में दिखाई दे गई तो, सच में आवाज़ आ गई तो दवाई खानी पड़ेगी. इट्स अ साइको. So that's a tricky MCQ and we have seen this question that it is a, so all symptoms are of depression but till death wish we say it's a normal grief reaction which has been said as a uncomplicated bereavement. We know more than 2 years of grief, it is the hypertrophic grief reaction. More than 6 months is a the prolonged grief reaction. ठीक है डॉक्टर साहब? ओके. Now, how to break a bad news? That's a very, very popular. We know doctors have been beaten across the globe nowadays. So, to prevent the beating, we have a spikes pattern. It's a setting up of the interview, perception of client, introduction, knowledge sharing, expectation, and summarize. So spikes pattern actually minimizes the the fight and the jagada in the emergency department, and when how to break a bad news. So it is a short form of the multiple words, setting up of the interview, perception of the client. Very good, Doctor Saab. डॉक्टर वर्षा, डॉक्टर नवराज कुमार, डॉक्टर संदेश, अब तो बहुत सारे लोग आ गए हैं, सॉरी, बट आई थिंक वी माइट हैव टू कट शॉर्ट दी क्लास and we take up the next Friday morning 10 a.m. to till we finish off. It was not possible to do or 1 or 2 questions, so that's all. Now, catatonic signs. All of the following are the catatonic sign except the cataplexy we know is a seen in the narcolepsy. Catatonic symptoms are mutism. It is the mutism, rigidity. Despite that, there is a waxy flexibility. So, and you mold him like this, he can be easily molded like that. And you leave him there, he will remain like this for days and hours together. So, they maintain the abnormal postures called as catalepsy. Mutism, rigidity, waxy flexibility, posturing, and they have echolalia, echopraxia, echo of a language, echo of a movement. And we have the automatic obedience. We know treatment of choice is electroconvulsive therapy, and we give the lorazepam challenge test. If we give lorazepam, sometime the symptom disappears. ठीक है डॉक्टर साहब? Yes. Cataplexy we have seen is found in the narcolepsy. So that's all about the catatonia. So we take up the last question. You know, the defect in the empathy, defect in the capacity to appreciate other people's feeling, especially is a core feature of, my God. एम्पैथी का डिफेक्ट तो डॉक्टर साहब एंटी सोशल पर्सनैलिटी में होता है. So they have no guilt, no empathy. It's a heavy question. Very good, Dr. Navarajan. Navajan Kumar. Yes. No guilt, no empathy. It's a classical feature of the dissocial. Now that's a very basic question. All of the following is a basic disturbance in the psychosis. It's all of the above. All of the above. And in clear sense. पूरे होशो हवाश में ऐसा होता है. ना डॉक्टर साहब, ना डॉक्टर साहब, ये गलत है, सवाल ही गलत है. All of them are correct. We have the personality deterioration, we have the hallucination, we have delusion. Question is, all are seen in the psychosis except. So question आता है, all are seen in psychosis except, where the answer is disorientation. Very good. In psychosis, there is no disorientation. Delirium differs from psychosis in. Delirium में क्या होता है? Delirium differs from psychosis in orientation. In delirium, there is a disorientation. Very good. Sensorium, orientation, very good. ठीक है डॉक्टर साहब. So we just take up this last question of IQ and wind up the today's class. I'm so sorry, but we'll completely enjoy the remaining slides to come. So IQ we all know is a IQ is equal to, mild is IQ is equal to mental age upon chronological age into 100. But please mind, the maximum chronological age is 16 years. After 16 years of age, divide by 60. So when this question will be asked, we'll do 9 by 16 into 100 is equal to something like that. It's straightforward question, sorry. Okay. So it's a 9 by 16 divided into, it is 15 ईयर होना चाहिए था. Divided by 15. So actually question is 25 years old. 9 IQ. So then trick applies that to divide only by, so we feel 9 by 25 into 100 is equal to 36. But that is wrong. In this question, we will divide by 9 by 15 into 100 is equal to 'So IQ formula is 9 mental age by chronological age, but the maximum chronological age is to be divided is 15 years of age. And we all know IQ, any IQ less than 70 is called mental retardation. In DSM-5, it has been called as intellectual disability. We know 50 to 70 is called as the mild MR. 35 to 49 is a moderate MR. 20 to 34 is a severe MR. Less than 20 is a profound MR. They are educable till 8th class. They are trainable. They are dependent. And they need nursing. So that is how the rule of the IQ. Okay. Mild, moderate, severe. IQ is equal to mental age upon chronological age into 100. And the latest question is simple question, lollipop question is that as per DFM-5, the mental retardation is being called as intellectual disability. So this will be categorized into the mild MR. Very good. Question is mild MR. So well done, Dr. Varsha and Dr. Navarajan, and thank you so much, you all. And we'll take up the remaining questions. But trust me, no question has ever come outside this 50 question. Sorry, we can't do in continuation today. We will wind up and we'll take up on Friday morning, 10 a.m. to 11 a.m. or maybe till when we finish off. Okay, good luck. Thank you.